The next session is on recurrent pregnancy loss, for which I would like to invite our honorable chairpersons, Dr. M.G. Dhanalakshmi and Dr. Jayashree Gajraj. Please may I have you on stage, ma'am? Dr. Dhanalakshmi is a professor and senior consultant in the Department of Obstetrics and Gynecology, Sri Ramchandra Institute of Higher Education and Research, Chennai. She is an undergraduate and postgraduate teacher since 1995. She is the executive committee member, the Obstetric and Gynecological Society of Southern India, 2023. She is the honorary treasurer, Chennai Menopause Society. Dr. Jayashree Gajraj is a senior consultant Obgyne practitioner in Chennai. She works in Apollo Specialties Hospitals and Mangai Women's Health Exclusive. She's an MGM Healthcare Gold Medal in Clinical Medicine and MBBS. She's the past president of FOGCE. She's the past chairperson of AICC RCOG, founder secretary and past president Chennai Menopause Society. She's a president in AT and RCOG, vice president SOFC Tamil Nadu. She got the Best Doctor Award from Dr. MGR Medical University, and she has various publications and chapters in textbooks. Ma'am, may you please introduce the moderators?
Thank you very much for inviting Dr. Dana and myself to chair this session. I'd like to invite the moderators. Dr. Kunjumoideen, please join us on the stage. I think he's a very popular person in Chennai, and many of you have heard and seen him work as well. I'd like to invite him. He's a senior consultant at the ARMC IVF Fertility Center in Kozhikode in Kerala, and he is the founder of many societies in Kerala. Founder chairperson ARMC Aegis Hospital, and founder secretary IFS Kerala chapter, having done his MBBS from Thrissur and MD from JIPMER. Dr. Kunjumoideen as one of the moderators. Thank you.
I'm very happy to introduce our own Dr. Aruna Ashok. We have known her since her SRMC days, and she will go for her dreams, and I wish her all the best in future endeavors too.
I would like to invite the panelist, Dr. Yoga Shalini. She is an undergraduate from KVP Medical College, Trichy, and she is a soaring practitioner in Urapakam. I think many patients deserve her service. And we have Dr. Sudarshan. Yeah, Dr. Sudarshan is here. He is a consultant fetal medicine. I think nobody needs an introduction for him. We are very honored to have him here as a panelist in recurrent pregnancy loss. Yeah. Now I call upon Dr. Aishwarya, our in-house consultant, fertility specialist. We have a mixture of obstetricians, fetal medicine specialist, fertility specialist, and we have Dr. Lakshmi here, who is again a high-risk obstetrician from A4 Hospital. And we have Dr. Kanimuri is not able to join, unfortunately because of her health. So let us start the panel.
We can have both the chairpersons into the panel.
Yeah.
You can also be the chairperson. Yeah, start.
Let us start the presentation. So we all know that we all stand by evidences. So quickly to the panelist, Dr. Lakshmi is there in the first row. How many pregnancy losses do you require to start evaluating a patient?
We can start evaluating after 2 pregnancy losses. Even though there is another thing that we can go for investigations after 3, but the recent SRA guideline says that we can go for investigations after 2 losses.
Very good. So we all accept that fact that we wanted to evaluate after 2 pregnancy losses. So it doesn't make a big difference if we evaluate after 2, we are able to find out most of the causes. So we did not wait for the 3 pregnancy loss to happen. This is what the panelists also agree to it, I think. So Dr. Aishwarya, you want to tell what is primary and secondary RPL?
Primary is somewhere the patient has never conceived, has not carried the pregnancy beyond 24 weeks. Secondary is when she has conceived but she has not taken the pregnancy beyond 24 weeks.
Do you need the differentiation? Do you think that differentiation is needed by us, or it is the same for evaluation?
For evaluation purpose, yes, because in case of fertility perspective, it might be of some significance. Whether we need to do any fertility treatment for her will be definitely a questionable thing in case of RPL, because the first thing the patient will ask is, I've already conceived, why do you want to do an IVF for me? So something like that. So in that case, we can boldly tell, in the primary case, we can boldly tell, yes, you may need IVF and you also have this genetic problem or you have this immunological problem. So you would need additional treatment. But in case of secondary, it becomes slightly more difficult for us to counsel in cases of whether we need a fertility treatment.
So more than second trimester, if they're going to go more than 24 weeks, the investigations little bit are different when it is an early pregnancy loss. So it makes a difference for us to make a definition. So
the causes of pregnancy losses are plenty. Like you mentioned, the causes will be different once the previous pregnancy crosses the viability and once when we consider whether it is a early pregnancy loss. So there are plenty of causes. At least one of you can just narrate.
It could be genetic causes,
Yeah.
anatomical causes from the uterus, could be cervical causes.
So what is the common
endocrinological-
genetic abnormality which you have come across in your practice?
Trisomies.
Yeah. With regard to the congenital
Aneuploidies.
abnormalities, what is the common thing which
Aneuploidies.
you had come across? Congenital one.
Congenital anomalies.
Anomalies. In your regular practice?
Trisomy 21.
No, I'm asking about the uterine anomalies.
Uterine anomalies.
Trisomy is over.
Biconate uterus, septate uterus, both I have seen.
Do you think biconate uterus will cause?
Sir, the one I have come across in my practice, they have landed up in preterm. Only 2 cases I have landed up. One was septate uterus, the other one was at biconate
Yeah,
uterus.
we need not even treat the biconate uterus because it is not having any evidence relation with the recurrent loss.
So we will go ahead with immunology as a primary discussion.
I'll use this. Yeah.
So we'll go ahead with only immunology as the main discussion, because morning itself we had a genetics, and I think rest of the uterine anomalies, many of them are stalwarts in that. So immunology is an ever evolving field, and we have lots of doubts and newer things which is coming inside, and we have people telling us that you have to do so many things for the patient, so whether we are justified in doing all those. So these are the questions that the patient asks you. So why I had a recurrent pregnancy loss? So many a times we tell all these things to the patient, but this is not enough for the patient. Patient knew that a diet, exercise, lifestyle, although we insist on these things, they want something different and they want to be evaluated. They want to find out what is the cause for recurrent pregnancy loss. So this is the case 1.
Yeah, before starting the case, I would like to ask, what is the most difficult question from the patient which you had come across?
Why this happened to me? Why me? Why it's
Yeah,
me again and again?
No, you answer only one question.
Why this
Why it happened is a very common question. It's not a award-winning question, isn't it?
It's very
Madam,
difficult
what is?
to answer for the questions.
No, will it happen again?
Especially
very
when
difficult
it's
to answer, no?
unexplained, it's very difficult why this
Will it happen again? If they ask, it is very difficult to answer, isn't it? Even after all your evaluations, it's very difficult to tackle that situation. We'll go on to the first case, 28 years, gravida 4, para 1, living 0, abortus 3. And the first one was preterm stillbirth at 7 months due to abruption. Then she had 3 missed abortions and she had regular cycles. And the personal history, the family history of diabetes and hypertension was there. And the TORCH profile, toxoplasmosis, IgG positive, IgM negative, rubella, IgG low positive, IgM negative, cytomegalovirus again IgG moderately positive with M negative, and herpes IgG mild positive, IgM negative. It's little bit confusing, but you just remember it because you won't get this slide back. Autoimmune profiles, that's why I put so many things
And to
to
the
check your
audience,
memory.
our dear moderator didn't want to share the slides to the panelists, so it is all on the stage. They are having the panel discussion.
No, it's a experience in your practice, no, actually. So the bleeding time, clotting time, platelets. Platelets is 1.2. You just note prothrombin time 13 seconds versus 11 seconds. Anticardiolipin antibodies, IgG highly positive, 181 units, and IgM again positive, and lupus anticoagulant positive, and double stranded DNA antibodies that also positive. So hope you noted all the positive findings. So next one. So See, there are a lot of guidelines given with regard to the torch and other infections. So what is your current practice? Do you regularly do torch test and treat it?
No, I don't.
You don't want to treat it?
No, sir, I don't screen routinely.
So Sudarshan, this history of torch positive, IgM positive, does it have any correlation with the anomalies in the next future pregnancies?
No, sir. See, infections, once they come, the person is immune to that.
Yeah.
So it's not going to cause recurrent pregnancy.
Exactly.
loss at all.
So that is a clear-cut message. We should not treat it. You can see the guidelines. So all the guidelines are telling the diagnosing and treating torch is not as per the evidence-based. Whereas the chronic endometritis and bacterial vaginosis has some correlations. Does APLA cause early pregnancy loss? Early pregnancy loss. The question is very specific. Does APLA cause early pregnancy loss? Anybody?
Yeah, it causes early pregnancy loss.
So it has clear-cut impact on the cytotrophoblast, inhibition of cytotrophoblastic invasion and differentiation. That is very much essential for the healthy pregnancy to grow. And it has a lot of immunological functions, and clinical presentation includes fetal growth retardation, potentially leading to fetal death in the second and first trimester. And prevalence of APS in RPL. APS is found in 10% of unselected patients with RPL, whereas 30% of patients with recurrent second trimester pregnancy loss has APS. So it is more correlated with the second trimester loss and the bad outcomes than the early pregnancy. Yes. What are the other immunological factors? These are something theoretical, but I would like to make a note on the SLE. It has good connection, and counseling is very critical in patients with SLE and RPL. And international consensus classification criteria that you can just go through, but just clearly see the clinical criteria. Can anyone of you just summarize the clinical criteria versus the laboratory?
Either there is a vascular thrombosis and pregnancy event. That is, loss of pregnancy is less than 10 weeks of gestation, or one preterm labor because of complications of severe preeclampsia or abruption, and 3 or more unexplained consecutive losses. After the 3 or more unexplained consecutive spontaneous abortions before the 10th week of pregnancy.
Yeah. So this classification you can very well, it's available in the journals, and this laboratory versus the clinical. Of this, the most important clue is that previous history of preeclampsia that very often we miss to evaluate, isn't it?
So what are the therapies available for immunological disorders that you give routinely as per evidences? Dr. Aishwarya.
Evidence says we have to start ecosprin in the preconceptional stage. Usually we start it in the, when we start ovulation induction or any therapy, we just give the ecosprin. And post-conceptionally, once the beta-HCG is positive, we can start on low molecular weight heparin, depending on her weight, 40 or 60 milligrams.
So here you start heparin. When do you want to start heparin?
Beta-HCG positive, not after heartbeat. Beta-HCG positive.
Beta-HCG positive. So when will you start aspirin?
Preconceptionally.
Preconception. How many weeks before?
Like once the patient is with us, usually we prefer to start
See, in spite of our treatment, patient may not conceive in next 6 months, 7 months, 8 months. Isn't it?
When she is coming for the first ovulation induction itself, we usually start.
So she may be ending up in taking for 2 years, 3 years aspirin. Actually, we can say in that situation, only in IVF cases we can specifically say when we start on the start preparing the endometrium for embryo transfer in frozen cases, or in case of fresh transfer right along with the stimulation, isn't it? So maybe 3 months or 2 months, that is quite sufficient. But in other cases we cannot predict, isn't it? Okay.
There are some prescriptions that we can see prednisolone being given to these patients. Are we justified in giving prednisolone to APLA positive patients? What is your opinion?
No rule for prednisolone. No rule for
There's no role for prednisolone because it increases gestation hypertension and other hypertensive
And
complications.
it actually creates a lot of complications. That's why it is being mentioned there. But there are some studies which is telling you can give prednisolone, but it is being prescribed even in case of recurrent implantation failure as well. So it is just like an empirical thing.
We have just talked about this. Echo sprint should be started before the ovulation induction or patient trying for a baby, and heparin should be started on the day biochemical pregnancy has been confirmed, that is beta HCG has been done or urine pregnancy test is positive. Starting it late may cause, this is a real scenario we had, so because it is discussed I just skipped it. So we had a patient who had first IUD at 7 months, and then the patient had a recurrent pregnancy loss workup and she was positive for LAC, but the heparin was started a little bit late every time, and the only change that we could do for the patient was starting heparin right when she conceived, and sometimes when it's an embryo transfer it becomes easier that we put on heparin, but ovulation induction IUI it is very difficult to put heparin after rupturing of the follicle, so we can at least do it, make a note of these patients and start heparin when they become positive. That's what the evidences also tell. HRA guidelines tell that we have to give a heparin starting on the date of positive pregnancy test over no treatment. We are justified in starting heparin. So this is a patient who is 35 years and had 3 miscarriages. 4th one was 16 weeks. She managed up to 16 weeks. 5th one she managed up to 8th month. APLA was done twice and it became negative. Hormones were, thyroid was little bit subclinical hypothyroidism. HSG is a normal, parental karyotyping is normal. Patient came with RPL with 2 second trimester loss history. So would you like to do anything else for this patient?
Blood sugars.
Blood sugar. It was all normal. Hormones, everything is normal. I think these are the tests that we usually do. We have done all the things. So this is how the patient, this is a real-time scenario which we had. We are not justified in doing thrombophilia profile, or when a patient is having thyroid, do we do anti-TPO and TG? Is it required?
Yes. According to HRA guidelines, we should go for TSH and anti-TPO for all the patients with RPL. If TSH is elevated, a free T4 is valid.
If TSH is normal and anti-TPO is high, will it make any difference in the further management?
Yes, you can start a small dose of levothyroxine in that case.
No,
if there is an RPL.
Even TSH is less than 2.5.
No, not less than, just maintain TSH less than 2.5.
That's why TSH is normal, TPO is high. It doesn't have any significance.
No significance.
If TPO alone is high.
Yeah. So when the thyroid TSH is less than 2.5, high TPO, anti-TPO doesn't make any significance. We should not start them on Thyronol. But if the patient is having 2.5 to 4.5 and you have anti-TPO antibodies high, then we can start. We are justified in starting a thyroid medications as per the BMI of the patient. Hereditary thrombophilia screening, because we do acquired thrombophilia screening, APLA very many times, LAC, ACA and beta-2 glycoprotein. Hereditary thrombophilia profile is one which is tempting for us to be done because we want to find out something heroic and give to the patient. So we did this for the patient, and the patient had protein S deficiency and she was treated, but these are the tests that we do. And this one study which is done, published in North American Journal in 2014, which clearly tells, they did a survey and 46% of American doctors do screening for hereditary thrombophilia profile even without a thrombosis happening when there is a 2 second trimester loss. This is just left for open discussion, but the patient they didn't have a venous thrombosis. The patient didn't have venous thrombosis, but she had 2 second trimester miscarriages. So we did a protein S deficiency was noted. So a justification to give a heparin for the patient till delivery. So whenever you want to give heparin, Dr. Yogashalini, how long you want to give heparin?
Till 34 weeks.
Till 34 weeks. Are you going to stop it at 34?
34 weeks.
Do you have any difference of opinion?
I think we can continue it and also in the postnatal period. For 4
How
to 6
long
weeks.
before delivery you wanted to stop heparin?
It's a prophylactic dose, it's 12 hours. And
12
it's a
hours
treatment
before.
dose, 24 hours.
Yeah. So we wanted to stop 12 hours before the delivery and continue it even after
4
postnatal
to
period
6
up to
weeks.
6 weeks.
6 weeks.
So this was
High chance of thrombosis will be there postnatal.
So coming to antinuclear antibody. Do you test antinuclear antibody in your clinic? No. So fine. But there are sometimes patients who have, this patient is 32 years, presented with severe oligohydramnios. At the time of the oligohydramnios, ACA was positive, but after the 2 miscarriages, when we repeated the APLA profile, it became negative. So one time it becomes positive. After 6 weeks or 2 months, you check it again, it becomes normal. As per criteria, we have to have 2 tests 6 weeks apart, and then we have to get it positive. So we did everything for the patient. Then we consulted a senior rheumatologist, and because we don't have anything else to do for this patient, so we referred to a senior rheumatologist. They told a criteria called seronegative APLA. So we all believe seropositive APLA. I really don't know whether the seronegative APLA should be taken into account. This is what the literature search we did came to know. But it is useful for the other conditions, I think. It is for other, apart from obstetric conditions, immunological problems, it's for the other conditions. And so the doctor advised the patient HCQ and azathioprine. I called up the senior rheumatologist and asked, can we start on azathioprine? How can you start on azathioprine? How can you start HCQ? What is the justification? He told, you started, doctor, it will be helpful for the patient. Luckily, the patient continued and delivered. We still look at the evidence how to give these two. But I think certain times we have to refer to the seniors or other specialties. They can look into other immunological problems that the patient might have, which is beyond our discussion. So these are the tests that we have X-ray recommending. So X-ray recommends for other autoimmune conditions anti-nuclear antibodies. We are justified in doing it. The green ones are justified. The orange ones are controversial, and the red ones are not to be done. Natural killer cells, CD16 and all these things are not to be done. So I think we are not doing it. But here is a patient who is there with us in our clinic. She has had 6 miscarriages, 9 embryo transfers, and still we are not able to make her pregnant. All the tests, whatever we do, becomes to be normal, and she's really young, 30 years with 6 miscarriages. So we are troubled by these patients. So only we called Kunjumoideen doctor to moderate this panel and give us an opinion on how to manage these patients. So there are so many investigations which has been put forth in forum when there is more than 5 miscarriages. They tell all these. Whenever you wanted to fail a person, you can ask questions in immunology. They'll not be able to answer because all these are very, very high in our mind that we cannot remember these. IL-6, 17, 18, we can't remember all those things. But the patient, we did a immunoprofiling based on the advices, and we had these report which showed TNF-alpha is high, CD3 is high, and these, we have not done justification according to evidence, we know that, but the rheumatologist and the senior immunologist are suggesting to do immunoprofiling to this patient, and we land up on these reports. So we have to go out of the way, and these are the which recommendations. Venitus has published a book on recurrent pregnancy loss lately from Australia. In his book, I had a personal opportunity, so I went to talk to him. Are you using all these products? We are not using all these products. He is telling there are research going on all these products. So we are trying to see what can be done for more than 5 embryo transfers failed or more than 5 pregnancy losses if it is happening. We all have heard about all these things, but I will over to you, doctor, for your experience.
See, actually, do any one of you have any experience with IVIG, intravenous immunoglobulin? Because actually, more than recurrent pregnancy loss, in case of recurrent implantation failures, these things will be very useful. Even though evidence is not supporting as real thing that you can use this, but considering the recurrent pregnancy loss and recurrent implantation failure, you don't have much options as a definite use. Even for heparin, even for aspirin, the starting time, continuation, everything is controversial. So nothing is there as per the evidence that you have to do this. But with regard to the investigation, there are clear-cut guidelines. So the role of IVIG is, it can be used in chromosomal normality in miscarriages. These are the proposed mechanisms. Immunological causes, IVIG is immunotherapy, and it can retain the cytokine balance. And main thing is, it can be considered. There are studies by Karp et al. Howard Karp is a person who has done a lot of studies on recurrent pregnancy loss, and many of the recommendations are based on his studies. So IVIG, it can be used as an empirical treatment and recommended for women who have RPL with cellular immune abnormalities, that is evidence level A, and low molecular weight heparin with LDA should be considered as the standard therapy in case of RPL with APAS, and IVIG treatment in case of unexplained recurrent pregnancy loss and implantation failure without immune evaluation is not recommended. And how do we do? Should we tell? Yeah, it's very simple. That is, dosage is 400 milligram per kilogram and frequency once in every 3 to 4 weeks. and timing early in pregnancy for recurrent pregnancy loss or from the start of IVF cycle for recurrent implantation failure, and treatment duration and further tests based on clinician's decision and patient's condition. And this is something again really controversial. Do anyone have experience with the transfusion of paternal leukocytes?
I think ma'am has started, Aruna ma'am has started doing now.
We are doing for last 7 years. So in spite of lymphocyte immunization, therapy should not be used as treatment for unexplained RPL, as it has no significant effect and there may be serious adverse effects. But that evidence is very strong. In spite of that, we do give paternal leukocyte, processed paternal leukocytes. We do administer weekly, once in a week for 5 weeks before the embryo transfer. And in case of recurrent pregnancy loss, then only we ask them to try for pregnancy. In case of frozen embryo transfer, once they become positive, we continue for 2 more weeks. So it has given a tremendously very good result in our practice. We almost might have completed more than 500 cases. But where then world over the evidence is lacking. So just because the article and the literature is telling that it is not having any evidence, your clinical experience also matter in these situations where most of the treatments are empirical.
Just this discussion to Dr. Sudarshan we can ask.
Yeah,
You can
please.
see the case history and give your suggestions what you wanted to do as a fetal medicine specialist.
So we've seen that all her miscarriages are all in the early pregnancy by around 6 to 7 weeks, and there is no significant medical issue. She's only 24. I think you have done the rest of the investigations. If none of the miscarriages have been karyotyped, it will be worthwhile to do a karyotype for the couple first. Husband and wife will do a conventional karyotype if it's not been done with 4 miscarriages. Yes.
Do you wanted to suggest them they should have done a POC karyotyping for this patient? Do you believe in that or not?
So if they have the second miscarriage, if it happens after that, it may be worthwhile to send the products of conception for karyotype. In what way it will throw clarity is if it shows an aneuploid fetus, then you know that and the aneuploid fetus, what you have seen is one of the common trisomies. Say it is a Turner syndrome or it is a trisomy 21. Each of those has got a specific recurrence risk. If you have a Turner syndrome, it's usually sporadic recurrence. If it's a trisomy 21 in that karyotype, then you go and check the parental karyotype. If the parental karyotype is normal, what you provide them at least for that pregnancy is you get a closure for that. That is, you know that this is a random event which has not been related to this particular genetic cause. So do I advise to send the products of conception for a testing? Yes. After the second thing, yes, it may be worthwhile just to get a closure to why that problem happened. And if we find that the POC is actually normal, then it opens a can of worms because it's a euploid pregnancy loss which has happened. So you need to go and start investigation over and beyond that.
I think we'll close this case and then we'll go to the concluding remark by Dr. Kunjumoideen. Take home points will go.
Can I add one?
Yeah, sure.
Just one sentence that I'd like to add, if I may. The very first case that you presented, where the rubella was low IgG positive, I would strongly urge that you repeat the test and ensure that she has adequate antibodies before you proceed with all the other treatments and investigations that you have done. You may do all this, have a successful pregnancy, and she may get exposed to rubella and have a rubella afflicted child. So please make sure that you are confident she is immune to rubella before you go through all the other tests.
Definitely that point is tested.
And before concluding, I would like to say that with regard to the recurrent pregnancy loss management, with regard to the management, except the investigation, the treatment wise, almost everything is empirical. Even the PGTA, it has been introduced as that we need to do for almost all cases of recurrent pregnancy loss, early pregnancy loss. So the evidence is lacking for the routine use of PGTA if the parents are normal. So to conclude, with regard to the uterine factor, a 3D ultrasonography, sonohistography, histosalpingography, or hysteroscopy or MRI are equally good, and hysteroscopic resection of septum, myomectomy, hysteroscopic removal of polyps or adenolysis can be beneficial. And a subseptum or biconate uterus you need not touch at all. Antiphospholipid syndrome, apart from the investigations, the heparin and aspirin can help you. And endocrine abnormalities, all the abnormalities have to be corrected and balanced. And genetic, the most important thing is karyotyping of the products of conception if possible, and the karyotyping of the parents and the history of consanguinity, that are very important. And genetic counseling have to do appropriately regarding what to do next, and further investigations like exome sequencing, etc. And we need to control the environmental factors, the screening for smoking, drug use, excessive alcohol, caffeine intake, and lot of environment pollutants. And psychologically need to give good counseling. And the unexplained, there was a role for PGT, but the evidence is against it. And luteal phase deficiency, of course, it can cause early pregnancy loss, specifically when you have induced ovulation or in PCO patients where you have to support it appropriately. And infections like bacterial vaginosis and chronic endometriosis should be treated. And the male factor, there is a growing discussion on the role of male factor and increased DNA fragmentation that can also contribute to the increased pregnancy loss, and that also should not be spared. Yes, please.
So science can find out only 50% of the causes. We all know, and it's evidence-based. So 50% of the causes are still unexplained. We found out this paper where the tender loving care, correct follow-up visit, weekly medical and ultrasonographic examination, instruction to avoid heavy work, travel and sexual activity has significantly improved the success rate of live birth from 36 to 85%, so which we all are giving as of now, and we should continue without losing our patients. And when we have a patient with 6 to 7 miscarriages or 5 miscarriages in our clinic, in a busy practice, we tend to miss certain things which are as basic as thyroid or sugars, DTT being done recently. So we should have a checklist in our hospital, and we have to have a recurrent pregnancy loss clinic dedicated for these patients. Otherwise, we don't do justice to them for continuing the pregnancy. I thank the panelists for making the discussion better. I thank the moderator.
Yeah, in fact, we couldn't take the panelists for a clear ride. Didn't get much time. Thank you the panelists.
Thank you for that brain-wrecking session. I would request Dr. Aruna ma'am to please felicitate Dr. Kunjumoideen sir.